Well, good morning, everyone. I think we should get started now. I'm Neil Lane, University Professor and Senior Fellow here at the James A. Baker III Institute for Public Policy. So welcome to Rice, welcome to the Institute, and to this event this morning. It's been my privilege to chair a 19-member task force of Texans representing the best of medical and health policy communities, all of whom volunteered their time to analyze, to understand, and to make recommendations with regard to access to health care for the uninsured and the underinsured in Texas. Our report is entitled Code Red, and it is red so that one doesn't mistake it. Code Red, the critical condition of the health of Texas, because we believe that the patient, in this case the health of Texas, is in critical condition, and that immediate intervention is required to stabilize the patient and offset impending worsening of the patient's condition. Caring for the uninsured places extraordinary burdens on hospitals that serve them, on our trauma system, on our emergency rooms, and our other social services, and as a result, it affects all of us who live in Texas. The task force believes that the current level of Texans without insurance, that is 25.5%, using 2004 numbers, is simply untenable. Not only is this figure much greater than the national average of 15.7%, but the growth projections made by state demographer Steve Murdoch indicate the number of uninsured Texans will grow rapidly over the next few years in terms of both percentage and, of course, absolute numbers. Texas's vulnerability is enhanced because most Americans receive their health insurance through employment, and Texas is a state of small employers. In Texas, 73% of all businesses employ fewer than 50 individuals. Only 37% of these employers offer health insurance. And among those who do, only 1 in 3, or about 35%, of their employees can afford to purchase coverage. The proportion of the uninsured is highest among Hispanics and African Americans. Hispanics are a particularly rapidly growing segment of the state's population. Our studies indicate that those who are uninsured have higher mortality rates, have more untreated chronic illnesses, and less preventative care than those with health insurance. When these individuals do become ill, they receive care for which healthcare providers are only partially reimbursed through public programs. Hospitals and other health providers charge higher fees in order to subsidize their care. The insured pay for the uninsured. We estimate that over $1,500 of a family's health care premium is used to pay for this cost subsidy each year. Finally, the rising tide of uninsured is placing increasing pressure on local taxes in counties where a significant amount of care for uninsured patients is provided. A summary of the report is available for anyone who wants a copy. Pre-publication copies of 2 volumes report are available to the media and will be available in final printed form later this week. If others who are not here or not in the media would like a printed version of the report, they can get in touch with us, use our website, and we will certainly make those reports available. The entire report will be available later this week on websites at several universities, so it'll all be online, including websites of the University of Texas system. This study was undertaken with the financial support of 10 health institutions across the state of Texas, including all 6 campuses of the University of Texas system, Texas Tech University Health Science Center, Texas A&M System Health Science Center, University of North Texas, and Baylor College of Medicine. However, the report does not represent the opinions of any of these institutions or of any other specific group beyond the task force members themselves. The members' names are included in the material with associated organizations for purposes of identification only. But again, the opinions reflected in the report are those of the task force members only. We're happy to be able to say that with the exception of a single dissent on a single item indicated in the text, the report represents a unanimous view of the task force. Our goal was to gather as much data as possible, to analyze it carefully, and to indicate our findings and recommendations without any political or partisan biases. We made every attempt to be objective and analytical in our work, and we commissioned 6 papers, which are included in the appendices, the sort of largish volume here. Our report has been subjected to independent peer review, and the report, and in particular these 6 research papers, we feel represent important resource documents for anyone attempting to study the issues addressed in the report. I'm joined for the conference by other members of the task force, including Dr. Mike McKinney, and Mr. David Warner, and my vice chair for the study, Dr. Jack Stobo, and each of them will briefly address the major findings and conclusions of the report. And so I'll turn it now to Dr. Stobo.
Thanks, Neil. My name is Jack Stobo, and I'm vice chair of the committee. Although our task force reached many conclusions, we want to emphasize today our principal findings. First of all, it's important to understand that the overall health status of Texas is indeed poor, particularly in comparison to other states, and it's likely to decline even further without major and immediate interventions. Whether you look at immunization rates, mammography rates, mortality from diabetes or hypertension, there are significant weaknesses in the health of Texas. And all of this will be accelerated by rising rates of obesity, which is an increasing problem among our children. With obesity comes diabetes, high blood pressure, kidney disease, and other ailments. As noted by Dr. Lane, Texas has the highest proportion of uninsured individuals in the United States. We were very impressed by the efforts of some Texas communities were making to improve access to health care, particularly for the uninsured, and we have documented a number of these innovative approaches in our report. At the same time, emergency rooms across the state continue to provide an increasing proportion of care, which is both inexpensive as well as inefficient means of providing care to the uninsured and underinsured in Texas. The overall continuing rise in Medicaid costs and other health expenditures in Texas is unsustainable and clearly has a detrimental effect on the ability to fund other critical state needs. At the same time, it is clearly necessary that additional resources be available in order to properly address the problem of the underinsured and uninsured. On the resource side, it's clear that the state of Texas has not taken full advantage of federal matching funds for health care to the uninsured. It is also clear that the current county-based approach to health care is inadequate and inequitable. Many counties provide care for individuals at such a low percentage of the federal poverty level that they exclude a large majority of uninsured individuals. Moreover, in the absence of support or facilities in these counties, the patients come to large metropolitan centers such as Houston, Dallas, San Antonio, Galveston, and Austin to seek care through emergency rooms which cannot turn them away. These counties, whose patients go to other counties for health care, often accept no financial responsibility for the care of their own residents. There are some outstanding examples of counties which do accept responsibility for their uninsured patients, but these are the exceptions rather than the rule. As Dr. Lane noted, Texas is a state of small employers, relatively few of whom offer health insurance. Only 37% of employers with 50 or fewer employees offer health insurance, and their premiums are usually so out of reach that only a little more than a third of their employees actually purchase insurance when it's made available to them. It's worthwhile to remind ourselves that health insurance for a family of 4 now costs an average of approximately $10,000 in premiums alone per year. A family of 4 at 100% of the federal poverty level, which is $18,000, would have to spend over half of its income for such insurance. At 200% of the federal poverty level, or $36,000 annually, a family of 4 would have to spend over a quarter of its income on health insurance premiums alone. Yet, in the face of these daunting and in fact impossible to pay costs, the state has not taken full advantage of federal matching funds that would help us provide health care to the uninsured. We believe that this practice must change. Additionally, we believe that the state must find a way to subsidize payments by small business employers and employees in order to make health care coverage more affordable. Beyond these concerns about coverage, we also have a significant shortage of health care professionals in Texas. which limits our capacity to provide care, particularly for the uninsured and for Medicaid recipients. Efforts to increase the state's capacity for training health professionals could significantly increase the availability of care for the uninsured. Finally, patients with mental illness pose a special, very large unresolved problem for Texas. Any successful solution of the access problem for the uninsured must include an approach to behavioral and mental health services. My colleague, Dr. McKinney, will now continue with the discussion of our principal recommendations.
Thank you. Well, the task force recognizes that many of the aspects of the health care and health insurance problems are nationwide and require national solutions. We focused in our task force, we focused on what could be done and should be done within Texas. The task force recommends, first off, that Texas adopt a principle that all individuals living in Texas should have access to adequate levels of health care. This recommendation based on the need for improved health among the uninsured, but also it's important to note that it's based on the impact that a large number of uninsured people have on all of us, on all Texans. To achieve the goal of adequate health care for all, additional resources are required. We believe that it is essential that any new monies, and there will be a need for new monies, but that any new monies be used in a manner that will be more rational, provide cost-efficient care, as well as quality care, and help to slow the rate of growth of healthcare costs. As a result, we recommend that any new infusion of state dollars be used to create a virtual coordinated care system. Essentially, a coordinated care system is a virtual HMO for the uninsured. This would be a system whereby the uninsured patient would be enrolled at the first contact with a provider. An electronic health record is a very important piece of that. It should be created in order that studies and medication would be available to all providers, help avoid duplication of tests, provide a clear understanding of patients' problems and past treatment that they had received, and it would be available to all providers, all physicians and other providers. The Seton system in Austin is an example of a place that has demonstrated the feasibility of this form of electronic medical record and this type of electronic interface and approach to the care of the uninsured. This approach will require a significant expansion in the number, size, and quality of community-based outpatient health care facilities. When an uninsured individual is discharged from a hospital after an illness associated with diabetes, hypertension, asthma, lung disease, heart failure, for example, they could then be referred to one of these outpatient facilities for disease management and coordination of their follow-up care by a multidisciplinary team. Emphasis would be placed on those individuals with high-cost illnesses, illnesses that necessitate frequent visits to the emergency room and readmission to the hospital. Because of the substantial shortage of healthcare providers in the state of Texas, that's doctors, nurses, and others, the task force recommends additional investment in the education of physicians and nurses. An expansion of the number of medical residents trained in the state would have two impacts. First off, it would increase the number of physicians eventually eligible to or available to take care of the uninsured in Texas. Residencies most likely determine where a doctor will practice when they get through with the residency. But also during the residency, they could serve at the community-based sites as part of an effort to provide a more rational ambulatory healthcare system. They are, in fact, physicians, but they're physicians in training, and they could be used in these ambulatory healthcare systems. The opportunity to gain and retain federal support for FQHCs, for federally qualified health centers, should be aggressively pursued throughout the state. Texas lags behind other populous states in the number of federally qualified health centers that we have available to our citizens. Recent state support to encourage the development of such FQHCs has increased the number, but there are still many areas, including Harris County, that would benefit from more of these centers. We can find ways for these centers to be operated in collaboration with other institutions, in collaboration with the medical schools, with the nursing schools, with hospitals, and so that medical residents, again, could participate in staffing these centers. Many of these centers would benefit from help with resource management and expertise from some of these more comprehensive established medical institutions. It's not to, and I think, frankly, the medical institutions would benefit from some of the social and neighborhood contact of the FQHCs. Improved materials for routing patients to appropriate ambulatory services are essential. Experiments, again, through the Seton Healthcare System in Austin, have demonstrated that a telephone call center just staffed by a nurse, by a medical professional, can redirect calls from inappropriate use of the emergency departments to a more appropriate setting for care. They found that 62% of calls resulted in redirected care at a more appropriate setting. Also, the Memorial Hermann Healthcare System in Houston, I know over at Southwest Memorial, has established a cash-only ambulatory care center that's essentially across the street, and that has decreased the number of non-emergent visits to the emergency room and provided effective services to both adults and children in that area. Enrolling the uninsured in a virtual coordinated healthcare system would allow more extensive use of disease management programs in which multiple providers, including doctors, nurses, nutritionists, social workers, and others, would provide care to individuals with chronic illnesses. Such programs should also include enhancement and care specifically for individuals with mental health needs, behavioral health needs, and dental health care. Texas needs to be more daring and more experimental in its efforts to improve coverage for the uninsured. Since there is no perfect solution that has yet been identified, and it is uncertain whether a solution in one state can be successfully transposed or translated into another state, it is essential that Texas actively test a variety of possible solutions. Among the most important kinds of experiment that the task force endorses immediately are those related to health insurance subsidies for small employers and for individuals where there are who work in small businesses. There have been successes in several states with what's been called a three-share approach. That is where the employee or the individual would pay a third, where the employers would pay a third, and then there would be a government subsidy of federal dollars would pay a third. These experiments must be done in Texas. Other suggestions include use of health care vouchers, insurance mandates, that is a mandate for carrying insurance, not a mandate for additional coverages, but different mandating employers to carry insurance. Insurance pools and some others. All of them have some advantages. All of them would probably work. They all have some disadvantages. We have to experiment freely to find out which ones will work. I know Massachusetts recently announced a bold plan for uninsured coverage. There's many details that are lacking in that particular announcement. We shall see. Only by formulating a particular plan and carefully testing it can we come to any kind of conclusion on whether or not this will work in Texas. We need a Texas solution. As mentioned earlier, controlling healthcare costs is among the important factors in making health insurance affordable and increasing state funding in Medicaid. Preventive measures are part of the answer. Such measures are particularly important for our young people. We provide a detailed discussion in here of the interaction between health and education. Higher education, more education leads to better health. Turns out better health also enables better education. These two programs and two measures are inextricably tied together. The importance of exercise, proper nutrition, health education in our schools cannot be overemphasized. School efforts are crucial if we're going to stem the tide of rising childhood obesity, diabetes, hypertension, things tied to that. Now call upon colleague David Warner to discuss some of the remaining recommendations of the report.
Excuse me, may I ask, before we carry on, if we could insert a comment from Betsy Schwartz, who I know has to leave. Apologize, but I think it's important we get a brief comment from Betsy. Betsy Schwartz is Executive Director of the Mental Health Association of Greater Houston, and Betsy was a member of our task force, and we're very pleased you were able to come this
Thank
morning.
you.
David,
Thank you for this
thank you.
opportunity, and thanks for accommodating. First of all, I just want to comment how important it is that mental health and substance abuse issues have been included in this report, and that I have been invited as a member of the task force. Often, I think all of you know that mental health and substance abuse can be on the sidelines. And in this report, as you've heard from all the previous speakers, mental health is really center and really a major integral part. The report specifies the prevalency of mental health and substance abuse issues in Texas and what the impact of that prevalence is throughout all parts of our healthcare system. We know that there are at least, and these are very conservative numbers, 3.1 million adults and about well over 1.2 million kids that have very serious mental health and substance abuse problems. There, as you probably know, someone who might have really good insurance for health for other parts of their body do not have equal access for mental health and substance abuse treatment. At least 55% of Texans who have health insurance don't have any kind of mental health or substance abuse issues covered in their policies. The Mental Health Association has done a lot of work that shows the cost effectiveness of providing equal benefits for mental health coverage. The economic impact of not providing coverage is very costly. We know lack of productivity, increased absenteeism are all impacts that we as taxpayers and as citizens are paying for one way or the other. Texas is 47th in the United States in the amount of public funding provided for mental health care. So there's really a double-edged sword. On one hand, people don't have insurance. On the other hand, the public mental health system is so sorely underfunded that people who don't have insurance can't get public care. So what happens to those people? They end up on the streets, they end up in jail, kids end up in the juvenile justice system when they don't need to be in the juvenile justice system. And they, most importantly, as this report has discussed in depth, they end up in emergency rooms, which is by far the most expensive and least effective place for them to be able to get appropriate care. Perhaps the greatest tragedy of all is that we know what works. We know the solutions. The solutions that are recommended in this report are the same as the recommendations of the President's New Freedom Commission, which include equal mental health insurance coverage, as well as providing the kind of wraparound integrated systems of care services so that mental health and substance abuse treatment is integrated into all health care provision. We know that if all of these recommendations were implemented, not only would it be the humane thing to do, but it would by far be the most cost-effective solution in the state of Texas. Thank you.
Thank you very much. Betsy, appreciate you making that comment. And David, thank you for allowing me to change the order a little bit. So Dr. David Warner, please.
Thank you, Neil. As has been mentioned before, the task force believes that additional resources must be developed in order to care for the uninsured in Texas. We have emphasized that any additional monies should be used not only to increase coverage, but also to find more cost-effective and efficient ways to provide that care. The task force believes that the current county-based system in funding of care for the uninsured is both inequitable and ineffective. It places a major burden on those institutions with large safety net facilities and upon the taxpayers in those counties, while relieving those in other counties of a fair share of their responsibility. The task force believes that the best solution to the healthcare situation in Texas would be a statewide healthcare system. But given the strong history of local control in Texas, recommends the development of regionalization of healthcare and makes more suggestions about the methodologies by which such regionalization might take place. Further, we recommend that all counties in the state be responsible for providing care using a statewide federal poverty level of 100%. In other words, each county be responsible for funding care up to 100% of poverty, rather than the very low 21%, which is currently in force. 21% of the federal poverty level is only $3,600 a year for a family of four. A county should be mandated to spend a minimum of 8% of general tax revenue on indigent health care services. Currently, the county is mandated to cover up to 21% and is mandated to spend up to 8% if they need to, but the vast majority do not. Moreover, if these monies were collected by the state and incorporated into the Medicaid program, they would be eligible for a federal match of $1.50 for each $1 collected, and the aggregate funds could then increase the dollars available by 150%. In addition, the task force recommends that a quality assurance fee be imposed on all hospitals and surgical centers in the state. A 3% tax on all such revenues would generate about $1.1 billion annually in state general revenue. This could then be used with the $1.50 match per $1 of general revenue and bring in $1.7 billion in additional federal funds, also for the Medicaid program. Some 35 other states have some form of quality assurance fee or provider tax, and many have multiple such taxes on different classes of institutions. The task force believes it is unfortunate that Texas is not taking advantage of this matching program. As a result of, especially to cover people who could be covered under Medicaid. As a result of the additional funds received, the institutions caring for a large number of uninsured individuals could receive back a higher level of reimbursement for Medicaid patients for whom they provide care, and also indirectly for the uninsured patients for whom they care. Additional Medicaid resources would go to expand limited coverage to adults and families in poverty and to reinstate the Medicaid spend-down program. Currently, we have something called the disproportionate share program, in which additional funds are given to hospitals that provide a disproportionate amount of care to Medicaid patients and the uninsured. Because funding is so inadequate at this point, all of those funds are going just explicitly to pay for deficits in those areas, and not, whereas in many states they're available for innovative programs such as the 3-share program and some of the other things that were laid out earlier. A portion of these monies could then in effect be used towards developing electronic health records and further efforts with regard to ambulatory services. It's quite conceivable that adequate relief to hospitals and hospital districts with this additional money might mitigate the need for rising property taxes in support of health care in those counties that are currently make such heavy commitments. And it could conceivably produce reductions in some communities. Other indirect benefits would be increased Medicare reimbursement for the disproportionate care program under Medicare for some hospitals, and it would provide added funding capacity to localities to make more federally qualified health centers viable. That's one of the major problems in having the adequate number of federally qualified health centers. The task force took into consideration the fact that a number of institutions which provide little or no care to the uninsured would not be eligible for significant funding with the money generated through this provider fee. However, the task force believes that this is an appropriate contribution. Such institutions ought to make a contribution to the care of the uninsured and the quality of life in the state. There are a number of other areas in which increasing state commitments would draw down significant amounts of federal funding. These include an expansion of the Women's Health Waiver and an 1115 waiver for demonstration projects. Finally, the task force, which included many healthcare providers, reiterated the recommendation that all healthcare providers contribute to the care of uninsured individuals in Texas. For healthcare providers educated in a Texas medical school where the state has made a commitment of several $100,000 to the physician's training, or in nursing, dental, or allied health institutions, the professional commitment to dedicating a portion of the care to one's fellow citizens is part of professionalism. Many health providers in Texas make this effort, but others do not. Thank you.
Thank you, David. So I'd like to sum up then before we take your questions. Clearly, healthcare is a large and complex issue. The task force has made 10 recommendations and a number of sub-proposals. The solution to this problem, however, must be shared responsibility by many institutions, organizations, and individuals. It will require partnerships between providers, patients, communities, policymakers, businesses, and a host of other entities. The task force believes that good health is good business for Texas, and that a healthy workforce will be important for the well-being of individuals, families, communities, businesses, schools, and our state. Now, we'll be happy to take your questions. We want to restrict the questions to representatives of the news media in case there are others here, and then, of course, we can get your questions later. This news conference is being webcast, and we want everyone to be able to hear your question, and please identify yourself before asking your question. Then, after the members of the press have had a chance to ask their questions, if we have time and there are other people here, we'll respond to other members of the audience. So, I open the floor now for questions, please.
Alvaro Ortiz, Channel 57 at Stake on America. I have 3 very specific questions. First, how much of a financial burden is the health care of illegal immigrants in Texas? Also, what are the most worrying diseases affecting Hispanics here in the state? And also, is it a false myth or is it true that undocumented immigrants flood ERs in Texas?
I think, let me just comment on the first of your question, which relates to the last, and then I would ask our colleagues to maybe give more precise information. I think it really is a myth that a large fraction of the uninsured and underinsured in Texas derive from our undocumented aliens living in the state. It's difficult to get precise numbers on that, but let me ask if any of my colleagues on the panel would comment on that. David, you want to say a word about that?
Well, the estimates are that probably somewhere around 20% of the uninsured are undocumented. But that would only be about 5% of the people in the state. I mean, so, yeah, I mean, give or take. So if we could take care of the uninsured problem for other than undocumented, it would be at least quite a bit more manageable. There is some federal help now for undocumented persons, both emergency pregnancies and emergency room care. Medicaid has covered to a certain extent, and now there is a fund which has just become available, which is beginning to reimburse hospitals in the state for undocumented, although it's not a lot of money. I think it was something like $20 million for the last quarter in Texas, something like that.
Please.
David Warner. Oh, my name's Lee Hopper with the Houston Chronicle, and I had a question for Mr. Warner. One of the recommendations that I found the most interesting was the 3% tax on, or the quality assurance fee. Two questions about that. How far would that money go? That's nearly $3 billion once you get the federal matching funds. And then secondly, how will you get people on board with that? I mean, have you floated that idea? Is there some bipartisan support for it?
Well, I think it's an idea that's out there. I can't, and this is one that the task force endorsed. I did make a presentation to a committee that was set up by the legislature or called for by the legislature with a rider in the last session at Health and Human Services, which was looking at reimbursement of hospitals and also looking at some of the other issues. And but it was only as it was characterized as my presentation, so I'm not sure how much traction it has, but I think it's, in some sense, we see this as it really would only be an additional 1.7 billion, because in a way the money that the hospitals are putting up is going back in to the hospitals and to physicians to a certain extent as well. So, but it would draw down the additional 1.7 billion in federal money if we, made some of those changes in Medicaid. And so I think it's seen as interesting because there aren't very many situations where you can tax a group and they end up with a lot more money than they had when they started.
I might add to that, though, that there's a couple things. First off, there are hospital providers, surgery centers, and even some nonprofit hospitals who, in fact, do not provide very much care for the indigents. And it would be an opportunity for everybody to participate, to allow payments from people who don't take care of the indigents to participate in taking care of them. And as far as bipartisan support, that's the thing about this committee and about health status and health care in general. I mean, actually, illness knows no party lines, and I think that everybody, all of us, even if you have insurance, all of us are impacted adversely by the rate of uninsurance in the state of Texas. So I think there will be intelligent people on both sides of that aisle who will be supportive of it.
Other questions? Back in the back, please.
Two questions. Kind of following up on the last one. This is from Renee Bell from KPFT. Which of the ideas in the task force report here seem to have the most political traction, or have already kind of been floated out there and might be picked up most immediately? And what are some of the ideas that face more challenges, if you can just sort of sum that up? And the other question was, where do you see the political willpower having to come from in order to carry out some of the ideas presented here? Is it the county, the state, or other areas?
But Jack, you want to start on that one?
Well, it's hard to say which will have the most political traction. This is the first public presentation of the report, and it's responsibility of our committee to make the report available, and then leave it to others to work with some of the recommendations, whether they be in the legislature or they be other important leaders in healthcare throughout the state. So I don't think we're prepared to, as a committee, to say which has the most political liability or not. The second part of that had to do with the political will. I think if you look at the report and understand the enormous impact that the uninsured have on both the insured in the state in terms of the cost of health care, in terms of economic development and the negative impact that the uninsured have, the impact it has on education, the negative impact that lack of health insurance has on education, there should be a significant political will to address this, because it's going to be good not only for the citizens of the state, but for the economic health of the state of Texas. And it's just a question of getting the understanding and making the connection between the large number of uninsured and the negative impact it has on the state in terms of economic development, education, and the health and cost of health to the insured.
Mike, David, you want to add anything?
I'd like to say that in some ways, I'd say in the last 20 years, this is the third time that that the state has faced real challenges because we haven't fully taken advantage of federal situation. The first was really in the 80s. You couldn't get kids on Medicaid in Texas because they had to be on welfare in order to get on Medicaid. And it really took Senator Benson to change, when he was chairman of the Senate Finance Committee, change the laws on Medicaid so that it delinked Medicaid from welfare, and in fact mandated that nationwide, on a phased-in basis, that all kids under 18 be on Medicaid if they're under the poverty limit, and actually kids under 6 be on Medicaid if they're under the poverty limit, and pregnant women be covered. And that made a huge difference in Texas in relieving the local taxpayer and also providing adequate coverage for very poor children and pregnant women. Then in the late 80s and early 90s, when Bob Bullock was the comptroller and Bill Hobby was the lieutenant governor, Bob Bullock put together a series called Dollars We Deserve, and Bill Hobby put together legislation to develop the disproportionate share program, which has been a tremendous boon to the state and has also taken some of the pressure off the local taxpayer and provided at least a better kind of financial basis for Medicaid. Now we're at a situation again where local taxpayers are paying a huge amount in certain cities like Houston and Dallas and Fort Worth and San Antonio, where typically the tax rate is 24 cents on $100 of evaluation just to go to the hospital district. And largely these are unmatched tax dollars. So you're paying the full dollar when really if you could somehow bring Medicaid funding in, you'd only be paying 40 cents. And our belief is that it's important both to broaden the responsibility and also take advantage of the fact that these matching funds are here, and that you could do it. And so I guess we're calling for a long answer to your question. We're not trying to act for any particular politician, but we hope that public officials will see that this is a very important thing and that there are opportunities.
We point out in our report something I think everybody in Texas should be concerned about, that I mentioned earlier, that the insured, in fact all of us, are subsidizing the costs of not meeting health care for everybody in Texas. But also Texas is subsidizing California and New York by leaving on the table federal dollars that we otherwise would be able to use to provide these important benefits to people in our own state. And some of the recommendations we have in here are directly focused on getting these federal dollars, our fair share, if you like, to the state of Texas. Question, please.
Yeah, in regards to that, what you're saying is that the state has not taken advantage of as many funds that DC could send?
That's
Is that
correct.
plainly speaking what's going on?
Yeah.
And why is that?
That's correct. David, you want to comment on that?
Well, the problem is you have to have the matching funds, and in the legislature, when it faced serious problems in 2003, had to cut back some programs, and that reduced the funds available. I think we're saying that even if the legislature didn't appropriate additional funds, we think this is so important that that at least the state should take advantage of the ability to have this kind of a quality adjustment fee. I mean, some states it's 6%, but that is kind of and that is kind of where the cap is. The administration has had legislation to reduce the cap to 3%, which is why we made it 3%. Although that cap hasn't been reduced, it would still be possible to go up to 6%, but we thought that was probably extreme.
Dr. Shine.
Yeah, just a couple of quick comments to your question with regard to the issue of undocumented. I would just emphasize that first-generation immigrants are relatively healthy.
So kind of speak on the podium so that we can get the audio right, because otherwise I'm not going to get you.
All right.
Thank you, sir. Appreciate it.
Dr. Shine, why don't you identify yourself?
I think you all know Dr. Shine is Vice Chancellor for Health Affairs, University of Texas.
And senior advisor to this committee. I wanted to emphasize that first-generation immigrants are generally healthy. And there's good data that shows that compared to later generations, the cost of their health care is significantly less. Unfortunately, when they've been in this country for a while and make the changes associated with diet and other habits, their health tends to deteriorate. But in addition to the data that Professor Warner gave you with regard to the relatively small percentage of undocumented, their actual health care costs are even a lower percentage of the total costs that are provided to the uninsured. The second observation I'd make is to emphasize the point that Professor Lane made with regard to the cost that all of us bear, and I will remind you that health care costs are the single most important cause of personal bankruptcy in the United States and in Texas, the individuals who have substantial costs. And finally, with regard to your question as to the kinds of problems which the Hispanic population has from a medical point of view, they are the kinds of problems that we're worrying about in terms of the state as a whole. We're desperately concerned about the epidemic of obesity, about which the Commission of Health has been so articulate, and Hispanics and African Americans are particularly vulnerable to that. The diabetes prevalence in some areas of the state are reaching almost 1/3 of the population, an extraordinary figure, and those make them particularly vulnerable. But there are problems, specific infectious problems along the border, but I'm very pleased that in terms of some of those problems, for example, tuberculosis was a major problem and is now coming increasingly under control. But what is a major problem is immunization rates are very low. And again, the point that Professor Lane made, we have to keep reiterating. If we have whooping cough in the population because the rate of pertussis immunization is very low, then it's possible that other kids are going to get whooping cough, even though they may not be among the uninsured. Everybody is vulnerable if, in fact, we have very low immunization rates.
Thank you, Ken. Other questions? Okay, ladies and gentlemen, thank you very much. There's nobody else here who's not with the press, I think. Any questions from anybody? Thank you very much. Have a good day.
Okay, see you later.
Good night.
Thank you all.
Thank you, Neil.